days, I saw an email from one of the world's leading experts saying that it's impossible to treat most patients with hypertension. But there is no ethical reason to deny treatment for a disease that kills. It's certainly fine to prioritize those at higher risk, but not to deny treatment or the offer of treatment for those who would benefit. But to do this, we need a public health approach. We need the combination of public health and clinical medicine and primary care. This means a new approach for many clinical systems that focuses on algorithms, specific protocols of care, regular drug supply, task sharing, patient-friendly services, and accountability. Today's presenter is Dr. Sandeep or Sunny Kishore, Associate Director of the Arnold Institute of Global Health and Assistant Professor at Mount Sinai School of Medicine. Sunny has led efforts to add to the World Health Organization Essential Medicines list 4 different fixed dose combinations or FDCs of antihypertensive drugs. This is an application supported by Resolve to Save Lives, the George Institute, and others. The 4 combinations are an ACE inhibitor plus a diuretic, an ARB plus a diuretic, an ACE plus a CCB, and an ARB plus a CCB. All of these are proven to reduce blood pressure and prevent cardiovascular disease in a high proportion of those treated. He makes an eloquent case that FDCs can support each of these 5 key components of effective cardiovascular care. Drugs and dosages may vary, and we do think there is a need for more information on the optimal combinations and dosages, but the time is now to add them to the essential medicines list. I'm going to hand it over to Sunny and look forward to the interaction. Thank you. Sunny?
Thank you so much, Tom, and I'll wait for the slides to pop up. Thank you so much, Funke. All right, ladies and gentlemen, so my task is to outline a proposal called Making the List, why now is the time to declare that antihypertensive combination therapies are essential. And I've asked Funke to kindly control the slides so we don't have any errors. So what we'll talk about today is the WHO Essential Medicines list and why it matters, the global burden of hypertension and some of the key gaps, the rationale for a fixed dose combination for hypertension as an essential medicine. I'm going to drill down on guidelines, efficacy, cost, as well as resources. Now, I've been on the other side of these webinars, and so I know that my job is to be short, punchy, engaging, and allow enough time for questions and answers so we can hear from you. Next slide, please. So what is the World Health Organization's Essential Medicines list? So this was a list that was initiated in 1977 with 204 products. And nearly 4 decades later, 2017, has 433 products. The list has effectively doubled. The definition: essential medicines are those that satisfy the priority healthcare needs of the population. Meaning the idea is that these medicines are meant to be available at the cheapest prices possible, if not for free, for the population. So what are the criteria to make it on the list? Well, you have to address disease prevalence, slight weightage to diseases with high prevalence, public health relevance, clinical efficacy and safety, and comparative cost and cost effectiveness within a class. So who uses the WHO Essential Medicines list? Well, on the one side, it informs national or country level priorities, and countries will then make a national essential medicines list which can inform public sector procurement, and then sometimes these lists are actually tied to national health insurance schemes. And on the other side, the essential medicines list guides drug donations and priorities by United Nations agencies. So next slide, please. So I first heard about the essential medicines list way back when in 2002. So this was a press release from the World Health Organization at that time. Quote, "In a decisive move to strengthen action against AIDS in developing countries, the World Health Organization has today announced the first treatment guidelines for HIV/AIDS in poor settings. Parallel to that, the WHO has endorsed the inclusion of AIDS medicines in its essential medicines list." Now, this is an important point because it underscores the idea that defining and focusing on priority essential medicines with clear dosing formulations and linking these treatments to standard treatment guidelines is necessary for success. It was also an important moment to focus the world, global stakeholders, including manufacturers, governments, donors, procurement agencies, on a core set of defined medicines to scale. Next slide, please. So it turns out, it's little known, but it turns out that anyone in the world, frontline practitioners, researchers, medical students, nurses, pharmacists can prepare an application to the World Health Organization to add or delete a medication on the essential medicines list. So in the expert committee of the World Health Organization that reviews this meets every 2 years. So learning from the HIV experience, where treatment advocates and public health practitioners made the case for those treatments to make the list, about a decade ago, my colleagues and I around the world started to ask, well, who's doing this for cardiovascular disease? Where are the key gaps? So this is just a sampling of what our work has yielded over the past decade. So in 2007, our colleagues and I, we added simvastatin as a representative of the class of statins. In 2011, a modern beta blocker in bisoprolol. In 2013, we added a new indication. So you can add, delete a medicine, or if there's a pre-existing medication, you can add a new indication. So we added heart failure indication for spironolactone. In 2015, we went after thrombosis with clopidogrel. And in 2017, we added losartan as a representative of the class of angiotensin receptor blockers. So that's been our successes. We've also had some applications turned down. So one of those, as you see with the red arrows, in 2017, along with the George Institute, we had applied for a fixed dose combination for hypertension with a ACE inhibitor and a thiazide. And at the time the application was turned down, and the rationale that the expert committee gave, that they were concerned that listing a single fixed dose combination for hypertension would limit choice from the variety of combinations, components, and dosages available. So remember that point, it'll come up again. Next slide, please. So now, let's drill down on hypertension alone. So what medicines are considered essential by the World Health Organization to tackle hypertension? So this is section 12.3 on the World Health Organization Essential Medicines list. So you have in your toolkit amlodipine as a representative of calcium channel blockers. You have bisoprolol, as I mentioned earlier. You have an enalapril, an ACE inhibitor. You have your thiazides, and you have losartan, or as a representative of the angiotensin receptor blockers. Now you'll note on the right column, you'll see defined doses, 5 milligrams, 1.25, 5, et cetera, which is very important for focus. But you may also note a funny little box, a little square box on the left side of each one of these treatments. Next slide, please, Funke. So what is this square box? So the square box symbol is primarily intended to indicate similar clinical performance within a pharmacologic class. So you can't list all of the treatments of a class. So the WHO asks that you pick an exemplar, a representative, a medication to list. So the listed medicine should be the example of the class for which there's the best evidence for effectiveness and safety. And when there's no difference in terms of efficacy and safety data, the listed medicine should be the one that is generally available at the lowest price based on international drug price information sources. So for instance, when we petitioned to add the class of statins in 2007, we chose simvastatin because the patent by manufacturer had just expired and the cost went down by 97% in 6 months. So we now had a rationale that it was cost effective. Next slide, please. Okay, so now I told you about the essential medicines list at the international level, some of the criteria, some of the core treatments for hypertension. Then what happens? Well, an essential medicines list is important, but the goal, right, is to get these treatments into the hands and mouths of patients across the world. So then how do you translate this from the national or from international to national? So what we find is that roughly 30% of low-income countries have actually taken a lot of the core treatments for secondary prevention and actually placed them on their national essential medicines list. It's closer to 60% in middle-income country settings. And I mention that point because that is a key gap that I see. The diffusion and translation of core treatments on an international list, are they actually making it to national level? But suppose they do. Suppose they actually get on the national essential medicines list. That actually matters. So what we know right now, this is a study done by Health Action International in 23 countries, is on average when treatments are listed on a national essential medicines list, so you have a treatment and a defined dose, you see a median availability of 62% and 40% in the public sector. And let's be honest, that's still bad. But if it's not listed on a national essential medicines list, the median availability is less than half of that and 6% in the public sector. Now, many of you on the front line know that there are many drug supply issues and stockouts, and you can start to see where some of the supply chain breakages could be, at least from the essential medicines list point. We also know that downstream of, affordability is affected by a medicine being on a national essential medicines list. So in a study done in sub-Saharan Africa, we know that antihypertensives are 1.3 to 3.7 times less expensive if they are on a national essential medicines list. We need help in figuring out which countries actually have the core antihypertensives that I've shown you earlier on their national essential medicines list. Okay, but now what happens? So suppose it's on a national level. How do you then trace it down and drill down to the sub-national level? And in some settings, we've learned that central procurement is actually not the core model, but it's actually a decentralized procurement. So if you take the setting of India with its many states, some states in India have 153 total medicines on their essential medicines list, and some at the subnational at the state level have up to 1,400. So there's nearly a log-fold difference. How these processes are run, what sort of decisions and how they're being made, in my mind, is an opportunity for modernization and standardization with frontline providers and practitioners around the world. Okay, so I hope I've given you a little bit of an introduction to the essential medicines concept and how a group of researchers, students, practitioners around the world have looked at this over the past decade to try to modernize. So next slide, please, Funke. So now let's focus in on hypertension, the key burdens and some of the gaps. So the global burden of hypertension, as Tom affirmed at the very beginning, is big, right? So it's a leading cause of cardiovascular disease with 10 million deaths. Systolic blood pressure above 140 or diastolic blood pressure greater than 90. We know that reducing blood pressure reduces cardiovascular events. So what's the issue? Well, right now we have 1.4 billion people around the world with hypertension. And less than 15% of these are controlled, and it's less than 8% in low and middle income countries. And you see, of that 1.4 billion, 510 million individuals are treated for hypertension. So we've only got 37% of need. But here's the key point. In low and middle income countries, of those patients that are being treated, 70% of the patients on treatment are not controlled. So I'll say it again. So you have 510 individuals treated for hypertension, and in low and middle income countries, 70% of the patients who are currently on treatment are not controlled. So what are some of the insights that could help explain that? One is 6 out of 10 patients treated receive monotherapy, so just a single constituent, a thiazide or a ACE inhibitor, etc. But we know that 75% of individuals on treatment require 2 or more antihypertensive drugs. This, ladies and gentlemen, provides the opening for the next slide. Okay? Thank you. So for those who aren't familiar, a combination therapy is simply 2 medications or more combined into a single pill. And the scientific rationale is that disease is driven by multiple mechanisms. So wouldn't it be useful to attack a disease through those mechanisms with multiple agents? So and we've seen this, and in fact, some of these treatments are on the essential medicines list as a fixed dose combination for HIV/AIDS, for hepatitis C, for drug-resistant tuberculosis. So what would it look like for hypertension, one of the world's leading killers? Well, the potential advantages would be the following. A combination is more effective than increased monotherapy doses. I'll show you more about that in a moment. You see reduced variation in treatment response. You see simplified logistics for supply chain management, which gives you focus. That focus gives you a greater ability to train and to task share to scale. That focus gives you fewer steps in protocol-based treatment. From a patient view, it gives you improved treatment adherence because you have simpler dosing and reduced pill burden. And we argue that there's reduced aggregate cost to the system. So what are some of the potential disadvantages? Well, the patients must not have contraindications for either of the components. If adverse events occur, it may not be clear which medication caused it. And there is a challenge in individualizing drug titration. And so we'll address that in a moment as well. Next slide, please. So at the end of the day, right now in 2018, we can say that fixed dose combinations are definitely indicated for patients on multiple medications. If you're already taking 2 or more of these treatments in separate pills, they should be in a fixed dose combination. And they're now recommended as first-line treatment for virtually all patients. And I'll frame some of the contraindications that we'll get to in a moment. So fixed dose combinations are indicated for patients on multiple medications and recommended as first-line treatment for virtually all patients. So here's some of the benefits. It simplifies the protocol. This idea has been recently endorsed in the 2018 European Society of Cardiology, European Society of Hypertension guidelines. And if you want to look at section 7.5.2.4, there is a rationale for single pill combination therapy as usual therapy for hypertension. One of my colleagues at Resolve to Save Lives, Dr. Mark Jaffe, and his team at Kaiser Permanente, Northern California, have in fact used a fixed dose combination, a ACE inhibitor and a diuretic and a thiazide as the initiation treatment. And they have achieved remarkable control. It's 85 to 90%, much higher than the national average or the California average. There are some contraindications to fixed dose combination. So to be clear, if you have renovascular hypertension, severe renal impairment, or pediatric hypertension. Next slide, please. So, learning from 2 years ago, when the expert committee highlighted some of the concerns that they had, and thinking about the updates and guidelines and where the world has moved, we've now put forward a proposal for fixed dose combination for hypertension as a WHO essential medicine with Resolve to Save Lives. I'm going to drill down on 3 areas: guidelines, efficacy, and cost. And I'm going to make the case of why we believe fixed dose combination should make the list. Next slide. So as hinted at before, in 2018, we have international support on the guideline front for fixed dose combinations. Whether it's the American College of Cardiology, American Heart Association guidelines in 2017, whether it's the European guidelines in 2013, as well as the updated ones in 2018, whether it's a country level in India, in China, in Thailand, or the World Health Organization's HEARTS protocol, which is an evidence-based treatment platform. All of these affirm the use of dual combination as well as single pill or fixed dose combinations. And certainly for patients needing more than one blood pressure lowering drug, fixed dose combinations are definitively recommended. Now, one of the things in the American College of Cardiology and American Heart Association guidelines was they highlighted 4 treatments across 3 buckets. So one bucket, and effectively these buckets are mechanisms that drive some of the pathophysiology of hypertension. One bucket is the angiotensin pathway addressed through an angiotensin receptor blocker or ACE inhibitor. The other is a diuretic like thiazide or a thiazide-like diuretic like chlorthalidone, or calcium channel blockade through a calcium channel blocker. So the scientific rationale is that by using at least 2 treatments from these 3 buckets, you address multiple mechanisms of hypertension and you get more effective control than just with one agent alone. Next slide, please. So based on this, based on the guideline support, based on what we learned from 2 years ago, and based on what you've just seen from the American College of Cardiology, American Heart Association, we have put forward to the World Health Organization 4 combinations. One is an ACE and a thiazide or thiazide-like diuretic. Another is an ARB and a CCB. Another is an ACE inhibitor and a CCB. And finally, an ARB and a thiazide or thiazide-like diuretic. So what you also see here are the examples, the representative that we believe are useful. So for the ACE and thiazide-like diuretic, we put lisinopril and a hydrochlorothiazide. For an ARB and a CCB, you see a telmisartan and amlodipine. And so on and so forth. What we've also done is for the doses, we've given the WHO a low, a mid, and a high, so 3 dose options. So we believe that this addresses some of the concerns about choice, where you have not 1 but 4 combinations and you have a range of doses here. But this is an important point going back to the square box. We have petitioned for a square box for each one of these. So lisinopril and hydrochlorothiazide, for example, would be an exemplar of the class of those treatments. We have chosen these strategically because they are already widely used in settings, they are cost effective, and they have a wealth of evidence on efficacy and safety. But it also means if they have a square box that a country could choose what combination in particular would work for them. Next slide. So do they work? What's the evidence behind fixed dose combinations? So we've kindly worked with the George Institute, Abdul Salam and Anthony Rogers as part of this application. And we've seen a study with 14 randomized controlled trials, 5,000 participants for initial dual versus monotherapy for at least 4 weeks. You see a 27% improvement in blood pressure control without an increase in withdrawals due to adverse events. So this is important. We also see in a study of 42 trials, nearly 11,000 participants, that combining drugs from 4 classes produced additive blood pressure lowering effects, going back to the idea that you're hitting multiple mechanisms. So here the key point is the effect when you use a fixed dose combination was approximately 5 times greater compared to doubling the dose of monotherapy. You know, I was talking to my mother, who's a primary care physician, and she asked me, well, you know, why wouldn't I just double the dose of the diuretic or an ACE inhibitor? And the response is that you actually get more effect when you use a fixed dose combination than you would by just doubling a monotherapy dose. I've been advised by my colleagues at the George Institute that I must mention for the trialists in the audience that there are also pragmatic trials like the Straith trial, the Stitch trial, and Pathways 1 trial that also show that combination therapy was superior to monotherapy with no difference in withdrawals or adverse events. Now I want to echo Tom's affirmation at the very beginning of this. Here's the key point. Improving global rates by just 25% with dual or fixed dose combination therapy would increase the number of patients with controlled hypertension by 80 million, preventing 2 million strokes and heart attacks and more than 600,000 cardiovascular deaths over 5 years. Next slide, please. So for those interested in asking, well, it's great that you get hypertension control, but what's the evidence on cardiovascular outcomes? This is data that shows the effect of combination therapy versus placebo on coronary heart disease, stroke, heart failure, and death, both with studies that have greater than a 6 millimeter mercury reduction in systolic blood pressure, those with below, as well as all studies. The lion's share of studies actually, you see, have greater than a 6 millimeter mercury reduction in systolic blood pressure. So I'll focus you there. You effectively see a 25% reduction in coronary heart disease, 39% reduction in stroke, 52% reduction in heart failure, and a 19% reduction in death through the use of fixed dose combination therapies. Next slide, please. And for those wondering about subpopulations or special populations, either diabetic patients or the elderly or those with a higher or intermediate cardiovascular risk profile, we see in these settings as well, whether it's for coronary heart disease, for stroke, or for death, that there is a positive effect in favor of the use of fixed dose combinations. Next slide, please. So sometimes I thought it might be helpful to actually focus in on one example and to just walk you through our thinking so you see our logic. So here in this case, I've chosen a representative of the ARB plus CCB, so a telmisartan plus amlodipine fixed dose combination. So telmisartan, so it has a longer half-life than some of its peers, and it's available as a generic. And as you've just seen, the class of ARBs is now, as of 2017, on the essential medicines list. And amlodipine, calcium channel blocker, available as a generic, and it's widely available and used in low and middle income country settings, especially because you don't have to keep checking on the metabolic disturbances. But here's an example where a combination actually gives you a benefit. So we know that there is amlodipine-associated pedal edema, but the use of telmisartan in combination actually helps reduce the incidence of amlodipine-associated pedal edema. Next slide, please. So what we've done is ask the question, if you were to compare the fixed dose combination telmisartan and amlodipine versus placebo, or if you were to take telmisartan and amlodipine, so sort of drug A and drug B, and compare the combination to either one of the drugs or the other drugs, and if you were to do it at multiple doses, what do you see? So this is analysis kindly done by the George Institute for us. So what we see when you compare it to placebo, and I'm giving you multiple doses, low to high, you see effect on systolic blood pressure as well as diastolic blood pressure. You see that it favors fixed dose combinations, especially against placebo. But when you also look at the monotherapy, fixed dose combinations are superior to monotherapy alone, either telmisartan or amlodipine at the various doses listed here. So it just shows you our logic, and we've walked this through for every one of the 4 combinations. For the sake of time and clarity, I won't show you everything, but it's in our application. But this is the type of detail and logic that we've walked through to compare against placebo as well as some of the monotherapies. Next slide, please. Okay, so I've reviewed guidelines. I've reviewed some of the key nitty-gritty of our proposal. I've reviewed how we're thinking about efficacy, both for fixed dose combinations compared to placebo as well as monotherapy. So you might be wondering, well, what's this going to cost? What, are these expensive, et cetera? So using that example that I just showed you with an ARB and a CCB class, so let's look at the sort of global data. So this is from Quintile's IMS, 2013 and 2014, 11 countries, some middle and some high. And what you see here, I'll focus you on the setting of India and the United States. So if you look at India, one thing you'll notice is the average price per pill in euros is 0.01. 0.01, so it's actually one of the most affordable, or it's one of the cheapest prices that you see. And then if you look at the United States of America, it's 1.73. So there's nearly 170-fold difference between India and the United States of America. So these are important points. I'll get to the United States in a moment, but for now I'm going to drill down on India. So then we start to ask the question, well, if this is the price in India, can we start to ask, is the price of a fixed dose combination more expensive, less expensive, or the same as going to the market or going to a pharmacy and purchasing these pills separately? If you have to take drug A and drug B, then you have to purchase them separately. What's the sum cost of those compared to the cost of the fixed dose monotherapy? Next slide. So here's the punchline. The cost of fixed dose combinations is similar to or lower than the cost of monotherapy with the constituent pills. And this is to qualify in the setting of India. So the cost of fixed dose combinations is similar to or lower than the cost of monotherapy with constituent pills. So I'll give you an example. So if you look at fixed dose combinations with lisinopril and thiazide, the median unit price in 2018 retail was 0.06 per pill. And if you would look at the constituent monotherapy, say drug A, 0.045, and drug B, 0.013. So the sum of those median prices of those 2 monotherapy pills that you might have to go purchase anyway was 0.059. And you see the same story for telmisartan and amlodipine, and the same story for telmisartan and hydrochlorothiazide. So here the idea is that the cost of fixed dose combinations is actually similar to or lower than the cost of monotherapy. And I want to give credit to Abhishek Sharma for helping compile this figure. The second point is this is retail pricing, but we also have, I'll put it here for the sake of time and clarity, we also see in the setting of India for public sector procurement a very similar story. Next slide, please. Now I showed you that figure on the price in a country like the United States. And so what's going on there? And this is important, starts to fuel some of the rationale. So it is true that fixed dose combinations have been used at times as evergreening strategies and efforts by originator companies to reduce the price erosion once a molecule comes off patent. What Anthony Rogers was telling me the other day is that, if you see in the United States, drug A plus drug B is often 2 or even sometimes 5 times higher than what it should be. So it's sort of the opposite of what you just saw in India. And when combinations first hit the market or are scarce, they often attract a price premium. But here's the point. If all of the constituent monotherapies and their classes, including ARBs, are on the WHO essential medicines list, shouldn't it be the case that a combination of these essential medicines should also be there? And if there are concerns about global price, shouldn't actually including a medicine as an essential medicine focus the world on ensuring price reductions, just like we've seen in the case of antiretrovirals? It is also important to note that retail drug prices need to be contextualized within the potential cost savings for improved hypertension control at a systems level. Next slide, please. Okay, so I've reviewed guidelines, I've reviewed efficacy, I've reviewed cost. But going back to what Tom had laid out at the very beginning, here is the key point. If you have one slide to remember out of this whole talk, I want you to remember this. Fixed dose combinations improve every key component of hypertension control. They both amplify and clarify what needs to be done. And Resolve to Save Lives has an incredible focus on global hypertension control against 5 components: protocols, medication supply, community-based treatment, patient-centered care, and information systems. So Funke, this might be tricky. You might have to hit the thing 5 times. Thank you. Perfect. So for the protocols, you see simpler treatment algorithms with the use of fixed dose combinations. For medication supply, once supply chain managers and procurement agencies, you don't have to worry about so many different pills, so many different dosages, so many various components. If we can get the world to focus on a set of defined lists, just like we've seen in other disease cases, we will actually improve downstream availability. And all of you just saw, especially in countries that don't have these hypertensives on their essential medicines list, you have 6% availability in public sector. So we got to do better on the stockouts. Community-based treatments, when you have a fixed dose combination, you facilitate and focus task sharing for non-physician health workers, community health workers to actually track and trace and treat. On patient-centered care, you have lower pill burden, which improves adherence. And we've seen that time and time again, which is a critical point for the fixed dose combination. And finally, you improve your control, and that will actually give you demonstrable improvements in cardiovascular outcomes, as you've just seen. So I will maybe end where I began and affirm that just like we've seen in the case of HIV/AIDS 16 years ago, when the world can declare a critical medicine as essential, and you link it to treatment guidelines, supply, community-based treatment, patient-centered care, and information systems, you have the right recipe for scale, and we need the tools to make that happen. Next slide, please. So for those interested in further resources, the World Health Organization process of making an application, all the applications are publicly available. So ours is actually available on the World Health Organization's Essential Medicines platform at this link. And some of the lead coordinators of the application, Abdul Salam, Anthony Rogers, Tom Frieden, Mark Jaffe, and myself, have a correspondence published on fixed dose combinations for hypertension, summarizing the argument I've made here that was published in The Lancet right before the UN high-level meeting on NCDs. Next slide, please. I'd like to kindly acknowledge Abdul, Anthony, Mark, and Tom for their leadership and vision at Resolve to Save Lives for going after this. I want to thank Phil Groden, who's one of my very talented medical students at the Icahn School of Medicine at Mount Sinai, who helped me with this presentation, and to Norm Campbell for his key insights on the role of fixed dose combinations. And with that, I will thank you.
Thank you so much, Sunny. We're going to go ahead and open up for questions and answers. I will unmute the participants' mic so they can go ahead and voice any questions they have.
And this is Tom Frieden. While we have the first question coming in, I see a question on the screen for the Zoom meeting from Bangladesh, from Sheikh Mohammed Babu Soban. That combination therapy is better, but in Bangladesh the price is still high. So regarding the socioeconomic condition, will the patient in middle and low income groups be able to continue the medication? And that's the concern. It's an excellent question and a reality. What we hope is that by putting these onto the World Health Organization EML, they will then get put onto country EMLs. And as Sunny showed, that tends to result in a reduction in costs. In addition, as programs to treat hypertension scale up and standardize medications, there's the opportunity to identify specific drugs with specific dosages and purchase them in bulk and be able to benchmark a cost and then drive down that cost so that we can get more affordable drugs. What we're seeing is a cost as low as $2, $5, $10 per year for some of the best quality antihypertensive combinations. Sunny, would you like to add to that?
No, I think, Dom, you nailed it. I mean, I think going back to the HIV/AIDS experience and what we've seen in other settings, exactly as Tom is arguing, this is precisely why it needs to be on the essential medicines list. Is you focus attention, you can actually put government pressure, but then you also get economies of scale. So it's a very important question, but I think in part fuels the rationale of precisely why we're trying to add this on the essential medicines list.
I'm going to read another question that's coming in online Like in HIV, probably India could play a major role in providing the cheapest generics in hypertension as well. Would this scenario come true? We don't know. It'll be interesting to see. I will say that Resolve to Save Lives as an organization generally does not purchase or provide medications. However, we are in a couple of jurisdictions where they're scaling up and they need a starter set of medications. We are doing bids to see what the market is like, and we'll provide one-time medications for a couple of areas. And I think what we see is the market, well, we're still understanding the market, quite honestly. We don't know what it'll be like, who the major suppliers are, but it's certainly possible that you'll see some of the major manufacturers of generics or branded generics providing high quality at a very low cost. Remember, we're talking about 1.4 billion people who have an indication for treatment, of whom only 200 million or so are on treatment. So there's an untapped market of a billion people. Now, some people may say, well, it's impossible you could treat that many people, but people thought it was impossible that there would be HIV treatment for tens of millions of people, and that costs many times more. It's much more complicated. This is something which in high-income countries has been standard of care for more than a half a century and is not yet present in many countries. Sunny, would you like to add anything to that?
No, that's perfect, Tom. It's perfect.
And then I think we have Mohammed Jami Hussein on. Did you want to speak? Or maybe it's a question, which is understanding that it has to be on the WHO EML, but that's necessary and not sufficient because that also needs to be on the country EML. That's exactly the case. What we're finding as we've gone, what we've done at Resolve to Save Lives is to convene a series of stakeholder meetings in the countries, states, provinces where we're working. We bring in their experts, we bring in international experts. We say it's your decision. You decide what to choose as your algorithm. And what we've heard over and over again is, well, we would like to use a fixed drug combination, but it's not on our EML. And it's not on our EML because it's not on the WHO EML. So given that dynamic that we've had, all of the jurisdictions we've been working with so far have chosen monotherapy. And we support whatever the jurisdiction wants to do, but we've heard them loud and clear that they want for the FDC to be on the EML so that they can then have it on their state or country EML, and then that would result in a greater comfort of using it, as well as lower costs and the ability to get quality up as well.
Yeah, and I would just add for Mohammed, we know that there's 134 countries that effectively use National Essential Medicines list to influence procurement. But what we don't yet have is the same sort of scaled process whereby practitioners and citizens are monitoring the National Essential Medicines list and then making the point that Tom made of, well, you know, is it possible for these fixed dose combinations or modern hypertensive treatments to actually be on a National Essential Medicines list? And so I think it's a brilliant question, but I would also say it's an opportunity to do the same kind of work that we've done at international level, at the national level, to standardize these lists.
We have 3 comments coming in on the chat. Let me go through them one by one. First, is this really possible, especially after the last rejection? We're optimistic. We think that we've addressed the concern that the committee had. There's a greater understanding. There's concerns that the costs may be too high, but in fact, we think that if it's on the EML and we standardize the doses and drugs, we can reduce those costs substantially. Second question from Shravan Chenji is, what about lab investigations, which may not be available in primary health centers? Is biochemical monitoring feasible if patients are kept on FDC compared to monotherapy? And since it's easier to diagnose abnormalities when they're on monotherapy, especially where investigations are limited. Every one of these questions has been excellent. This is one reason that several jurisdictions have selected as their algorithm amlodipine 5, amlodipine 10, and then add either a diuretic or a RAS inhibitor or both, because you're minimizing the potential metabolic abnormalities. And what we're finding is that in many contexts where patients need treatment, regular biochemical monitoring is very unlikely to occur. Now, it's been studied that even in high-income countries, biochemical monitoring, even when recommended, generally doesn't occur, and there's no worse outcome for patients in whom it doesn't occur. Nevertheless, since it is recommended, it is something to understand, and this is an area for further investigation and further evaluation. For example, if you added an ACE or an ARB with a diuretic as the FDC after amlodipine, as one country is suggesting to do, that might balance the abnormalities in potassium. So this is an important issue. I'll go through these and I'll turn over to Sunny to add anything on any of them. Hello to W.R. Kidong from Vietnam, who says it's interesting and important presentation. Hope to introduce the country. This is an important point. Thailand and some other countries are saying, you know, we don't have to wait for the World Health Organization to put it onto our EML. You can download from the link that Sunny showed the full justification of this, and countries can add to their EML. We began this process, more than 6 months ago. It'll be another 6 months before the WHO EML actually considers it, April of 2019. So we'll see. And then Kidong also asks, what about the misconceptions of influential physicians? Interestingly, what we've seen in many countries is they all use the combination drugs in their private practices. There's actually a disadvantage to the public sector if it's not using the FDC, because it's seen as better for all of the reasons that Sunny went into. You get a much bigger impact by adding a low dose of a second agent than by doubling the dose of the first agent, and probably a lower level of adverse events. For example, when you double amlodipine, you get a lot of leg edema. So there are also lots of misconceptions about antihypertensive treatments, and something that we might do in a future webinar is go through some of those misconceptions. We see this repeatedly around the country, around the world, in terms of the role of beta blockers, who should get an ACE inhibitor, ACEs and ARBs. Some of the things are still debatable, but some are pretty clear, and the knowledge lags behind the reality. Kat Normil comments that a number of initiatives aimed at increasing access to NCD meds are underway. Defeat NCD Marketplace and the PATH Coalition come to mind. Is this important work by Resolve interacting with work of other NCD coalitions partnerships? Absolutely. We'll work with anyone who's helping to improve care and treatment. So this is an important area to be in. Some of these groups are just scaling up, and I think some of what we have to do is work with countries, because ultimately it'll be the countries that are purchasing the drugs. They will be spending the money. They'll maybe make a decision based on where national manufacturers are or most cost effective. We hope those decisions will always be evidence-based and for the maximum benefit of patients, and reducing to the greatest extent possible any co-payments that patients have to make. Another comment is, in Bangladesh, it would also be a challenge to make everyone follow the same protocols. Well, I think that's true not just for Bangladesh, but for every country in the world. One of the challenges we have is that doctors tend to be quite reluctant to follow protocol. This is one of the reasons we strongly encourage task sharing. We strongly encourage the involvement of nurses, pharmacists, community outreach workers, and the rigorous evaluation of outcomes. It's been shown now for more than 40 years that protocol-driven care does better. Patients are more likely to have disease control, they're less likely to have adverse events, they're less likely to have heart attacks, strokes, and other complications of hypertension. So in those situations, it's really important that we see what the outcomes are and then use that to improve performance. Sunny, anything you'd like to add on any of those?
No, I think that this hurdle of the misconception of influential physicians is important. I was telling you, I was talking to my mother, who kind of shared her, you know, because you're talking about changes in practicing that some physicians have done for 30 or 40 years. And for me, what I use in those settings, right, is you have guideline support. And so if physicians are raising those questions and they do have influence on treatment policy, I would say the European guidelines, in particular in 2018, are very, very important because they affirm in a very strong way the role of fixed dose combinations.
Sunny, here's a question for you coming in on the Q&A. Are country EMLs updated routinely?
It's a great question. I'll be honest with you. So I'm part of a consortium with the World Heart Federation called GLOPRO, and it's looking at exactly this question. The honest answer is we don't know. Some countries, if you look at sub-Saharan Africa, many of the country-level essential medicines lists have not been updated in the past 5, in some cases even 10 years. And so who's asking those questions? What are the protocols? we're actually trying to dig into some of those processes now.
Related to that, from Chile, we have a comment that it's very important that it get onto the WHO list because the national public health system is always seeing what the WHO says, and our local initiatives are always supported by personal efforts and not by the system itself. That's why we're very hopeful that this will get approved by WHO. And I really want to emphasize as strongly as I can, all of these medications are generic.
Yes.
There are multiple manufacturers for all. They're all safe, they're all effective, they're all evidence-based, they're all standard of care. They would be used for the treatment of any patient in any country, regardless of income level. And related to that, there's an interesting question coming from Guinea, from Musa Sise, that Guinea has so few funds in health. How can you involve government in implementing the treatment plan in the national protocol to treat hypertension in countries that allocate little funds in healthcare? It's a great question. Some of this is going to involve advocacy for countries to spend more on health. Some of it will involve good procurement, so that if the government just can't pay for the antihypertensive drugs, at least you could get high quality drugs that wouldn't have to cost more than a couple of dollars a year. We'd rather it be completely free to the patient, but we recognize that that may not be possible in all countries immediately. In Africa, most countries in Africa have hypertension control rates in the low single digits, less than 5%. And because of that, we're seeing a large number of strokes, heart attacks, and large expenditures on trying to scale up dialysis and even kidney transplant. But prevention is going to be much more cost effective. Next question is regarding drug forecasting. If we're going to go for FDC, will it yield the same level of accuracy as monotherapy and yield the expected level of stock-out-free situations? I'll comment first and then ask Sunny to comment. What I've seen in multiple countries is 1 month they have one drug, the next month they have another drug, the next month maybe the first drug or a third drug, and that's really difficult for the patients and doctors. So if you put the drugs together, you're going to have a much lower rate of stockouts. And you also simplify the logistics of the pharmacy. You can't have one without the other. So what we've seen with HIV and TB with FDCs is that it really reduces stockouts. Sunny?
Yeah, I think that's spot on. And I think the moment you do that and you clarify and focus, it becomes actually a global issue to where everyone is actually aligned on a common set of treatments, and that actually starts to ensure that there's more attention paid to it. If you have too many treatments, too many doses, it splinters attention and splinters focus. So this sort of brings it together and centralizes it on a common set of priorities.
Also, as we gain more experience with these, we hope there'll be more price transparency. So it's openly stated what the prices are. We've seen, as Sunny mentioned, 100-fold variation in prices for the same chemical, all GMP, high GMP quality. Sunny, here's a question for you. What's your assessment about the current practice or situation regarding the use of brand versus generic hypertension drugs in LMICs, given that the price and affordability and maybe the availability differ significantly?
Yeah, it's a very important question.
Generic.
It's a very important question. I mean, so I'll just go back to the point that all of the current treatments for hypertension and many for cardiovascular disease in general, and hopefully for fixed dose combinations, are on the essential medicines list. So I do think that using generic treatments is actually very, very important. In the case of fixed dose combinations, we've seen some of the innovator companies have started to combine these treatments, and then they have what's called evergreening. So then they say, well, this is a fundamentally different molecule, so the price should be high. And in my view, that's not good for fixed dose combinations or hypertension therapies in general. All of these are essential. All of these are generic. And so I do think putting a focus on using those treatments will be critical.
Great. So we've got 5 minutes left in our time. We've had a really dynamic set of questions and comments. We don't have any new questions or comments coming in, but we'll keep this open for a minute. Whoop, here we see a new one just now. Sorry for the background noise here in New York City. In Latin America, the medical community is against many other health professionals participating in the treatment of high blood pressure. Any suggestions for how we might change this? Well, this is a great question, and it's the case all over the world. In fact, you can kind of think about the evolution of healthcare. Early on, before professionalization, you have everyone doing treatment, and then the doctors try to control everything. And if you look at the most advanced health system, you see more task sharing, more involvement of nurses and pharmacists, and the evidence is very clear. The evidence is really incontrovertible that you get higher control rates, lower costs, better outcomes if you have a task sharing approach. But you have the Doctors Association that's quite against it. One of the things to emphasize is what we're trying to do here is to scale up the number of patients on treatment. When you scale up the number of patients on treatment, you can make a big difference by basically getting a higher volume, and then the doctors can be reserved for those patients with complications or with resistant hypertension. So let the doctors do what they do best, which is take care of the complicated patients. Meanwhile, the nurses and the pharmacists are not working independently. They're following the doctor's orders. They're following the protocol that the government has established. And I think in different countries, there'll be different possibilities of doing this. Sometimes it's a systematic way, one step at a time. This is another area for possible work or possible future webinar. Sunny, anything to add?
No, I think you nailed it.
Another question coming up is, do you suggest that a country place all potential doses of FDCs on their EML, or just one or two with one or two doses, and why? Sunny?
I have a personal preference for focus. We applied previously for the ACE inhibitor and thiazide. So I do think that, to me, is a very important one. The other one being the CCB plus ARB. I think at least those two is what I would say. And then when you look at prescription volumes and you look at the efficacy and safety data, we know that many of those are already in play right now globally. The dose question is an important one. I think at least 2 doses, if not 3. I think going with one, there's an argument to be made about using half pill, 1 pill, 2 pill. And I think, it's a possibility, but I do think having at least 2 doses and at least 2 combinations would be an appropriate approach that satisfies everybody.
Right, and I guess I would say, if I were in a country, there's a question of what's on the EML, and there's a question of what I purchase. And since the drugs are therapeutically equivalent, I'd want to get the lowest rates for high quality drugs possible. We have another question from Nepal noting that only about 1/3 of those on treatment have their blood pressure controlled. Apart from the issue of efficacy, there's the patient's low perception of the risks of hypertension, health literacy, and other factors. And any new or tailor-made strategies to increase awareness among the general population, because it's so important to treatment and control. Very important point. One of the things that is quite important, and Norm Campbell has made this point very eloquently, is that every doctor at every visit should be emphasizing this. This is the leading preventable cause of death. And the communication from the health workers, this is certainly a role that everyone in the health system should be playing, should be emphasizing that hypertension is a silent killer, that treatment is likely to be lifelong and also life-saving. There's also the possibility of working with media, what's called earned media, a newspaper, radio, television, articles, to provide information about hypertension, to increase health literacy. This is probably not an area where paid advertising of the kind that is done anti-tobacco, for example, is likely to make a big difference, simply because it is such a long-term issue. But by getting journalists and other members of civil society involved, we have the ability to increase awareness. So we're up to the end of our hour. We want to respect everyone's time. It's been really a very rich conversation, delightful questions. On the link site, we do have ways to communicate with one another. Funke, if you want to add anything about how people can continue this conversation going forward. And I do want to mention that we will have 2 more webinars before the end of the year. In the month of November, what we'll have is a webinar on sodium, and in the month of December, a webinar on trans fat. So the next one will be on November 15th at 9 a.m. Eastern Standard Time with Larry Apple from Johns Hopkins Bloomberg School of Public Health and Medical School. And the topic is the case for population sodium reduction. Sunny, and then Funke, anything more you'd like to add?
I would just go back to the point that right now we know that 70% of people who are currently on treatment are not being controlled. So fixed dose combinations have an important potential effect in reversing that.
Thank you, everybody, and thank you most of all for your commitment to improving cardiovascular health around the world. And we'll be communicating with you via links and also seeing you again November 15th for the next webinar. Thank you.
Thank you, everyone. The links webinar is now over.